Well, good afternoon, good evening, good morning, everyone. Thank you for attending this IFCC webinar on derived lipid parameters and navigating the data. I'm Tahir Pillay. I'm from South Africa, but I'm actually coming to you from the Elsevier headquarters in Amsterdam. And we have a galaxy of speakers, eminent speakers today. To speak on various aspects of the topic. So we have our first speaker, Dr. Sridevi Devaraj. Our second speaker is Dr. Patrick Toomey, and then we have Dr. Andrew Dunwalkup, and they're all actually from different continents. So Dr. Devaraj is coming to us from the USA. Dr. Dunwalkup is in Australia, and Dr. Toomey is in Ireland. So we'll kick off with the first webinar. Dr. Sridevi Devaraj is a professor at the Baylor College of Medicine in Houston. She's a professor in pathology and immunology, and she's also the medical director of chemistry and point of care technology. And she will be discussing the first aspect of how to look at derived lipid parameters. Please welcome Dr. Sridevi Devaraj.
Hello, everyone. And thank you for attending this webinar. I'd like to thank the IFCC and Dr. Pillai for inviting us, and we will get on straight to the presentation. Obviously, lipid parameters are a lot, and today the focus will be on the lipid measurements. Why we're doing this is because, as you all know, coronary artery diseases, cardiovascular diseases are the leading cause of morbidity and mortality worldwide. And in the United States, more than 600,000, and that is 1 in 5 people die of heart disease each year. So that is a big number for our healthcare to manage. And of those with heart disease, among all of the other diseases, vascular diseases, coronary artery disease is the most common, and with a morbidity of more than 370,000 people annually. And we all know from a long, long time ago, from even as early as 1980s, that the coronary artery disease risk increases as plasma cholesterol increases. We got this from huge population studies like the Mr. Fit study, where the mortality rate as well as the incidence increases when your serum cholesterol increases. We know in your arteries that you have monocyte macrophages that carry the lipid laden macrophages. And this is the scanning electron micrograph of an African pigtail monkey, which was fed cholesterol. And there you see these blobs of monocyte macrophages, which are engorged with lipid, trying to get into the subendothelial space and forming the fatty streak and then progressing to the fibrous plaque lesion. So when you look at the evolution of coronary atherosclerosis, it is an evolving process. Starts off with a normal artery lesion. Initiation starts off with cholesterol, LDL cholesterol, and modified cholesterol being taken up by the scavenger receptor on the monocyte macrophages. They enter the subendothelial space. They produce a lot of toxic products, including cytokines, chemokines, tissue factor, etc. And when that comes in contact with the blood, you get the clot. And if the clot is big enough, it vaso-occludes, and you get get an event. So up to the fatty streak lesion, their fibrous plaque lesion, it is regressible. So what can we do in terms of assessing risk, and how early can we prevent this increased coronary atherosclerosis and events due to these atherosclerotic events? So the other thing about The complexity of atherosclerosis is a lot of us walk with plaques in our arteries. Not all of us know about it. And the interesting thing is that you have the concept of the stable plaque versus the vulnerable plaque. And if you notice here, the stable plaque on the right side has a reduced lipid core, and the difference between the vulnerable plaque is this huge, large lipid core, which has all of these macrophages and which cause matrix metalloproteinases to cause a thinning of this lining, which results in eventually in the thrombus. So, what causes the stable plaque to become a vulnerable plaque? You know, there are many risk factors for atherosclerosis. All of them contribute to this, but there's no direct single marker that we have of the vulnerable plaque. We know that the difference, one of the main differences in addition to your inflammatory cells, is that it has a large lipid core. So let's focus on lipids today. And we have lipids have to be carried in the blood, and they are required for energy storage and energy production, steroid synthesis, for formation of cell membranes, bile acids, etc. And how they're carried in the blood is they're packaged into lipoproteins. So the lipoproteins are lipid cores, which have the outer circle of these phospholipids, and you see the triglyceride insides as well as the cholesterol ester. So these need to be carried in the bloodstream. They do so with the apolipoproteins. So you have many lipoproteins that you have. And here is a composition of the plasma lipoproteins based on their density. And here you can see the biggest, most fluffy lipoprotein is the chylomicrons. And then you have the VLDL, or the very low density lipoprotein, and the highest density is the high density lipoprotein, has more protein than lipid. And this yellow portion is the triglyceride. So chylomicron has a lot of triglyceride as well as VLDL, but LDL is your major cholesterol carrying lipoprotein. So when you look at it in terms of density, you can separate it based on chylomicrons, chylomicron remnants, VLDL, VLDL remnants, IDL, LDL and LP little a, and HDL lipoprotein fractions. So as you can see, when you talk about cholesterol and lipoproteins and triglycerides, you're talking about a plethora of particles or proteins, cholesterol carrying lipoproteins that are all not measured on our usual or routine lipid profile, and we will come to that shortly. So the major apoproteins in each of the lipoproteins include you have chylomicrons, VLDL, IDL, LDL, and HDL. And if you're looking at just the ApoB, which one of our next speakers is going to talk about, and I'm not going to focus on, you have these ApoB carrying lipoproteins, which is VLDL, IDL, and LDL. So this is a theoretical arrangement. If you put it in a centrifuge tube and ultracentrifuge this plasma, what do you get based on density? Like I said, the most fluffy ones are the chylomicrons. And the fasting state, you should not have chylomicrons unless you have a familial hypercholesterolemia disorder. And then you have your VLDL, which floats on top. IDL, LDL, and your HDL is your most high density lipoprotein with a lot of protein in it. So we know from, again, the Mr. Fit study, the Framingham Heart study, and many other studies after the statins have been introduced, which are the cholesterol lowering drugs, that if you look at coronary artery disease risk and LDL cholesterol, with increasing LDL, there's a increased relative risk of coronary artery disease. And if you reduce this LDL, it translates to a linear reduction in cardiovascular events. So it's important to measure it accurately. And I'm really not going to go into lipoprotein metabolism, except to say that you have dietary cholesterol and you have biliary cholesterol. Only one third about of the cholesterol comes from the diet. So, with your lifestyle modifications, you can definitely decrease one third of your cholesterol, and a lot of it is produced by the liver through the biliary system and the extrahepatic tissues. You have reverse cholesterol transport, which is the function of HDL. So the rationale for the screening is atherosclerosis is primarily a lipoprotein mediated pathology, and abnormalities in lipoprotein metabolism are attribute 50% of the population attributable risk of coronary artery disease. There's a very well documented relationship between total and LDL cholesterol levels and coronary artery disease risk. But the one thing that all of us need to know that lipoprotein concentrations are in a routine practice not measured but estimated. So, of course, early knowledge of a lipid disorder creates the best opportunity of early intervention. But how does one actually measure LDL cholesterol? So, the most often done in a lipid profile, for example, is that you have LDL that is calculated, right? So, you measure total cholesterol, you measure HDL cholesterol, you derive the VLDL cholesterol, which is your triglycerides divided by 5. And so you calculate the LDL cholesterol as total cholesterol minus TG by 5, which represents the VLDL cholesterol, and minus the HDL cholesterol. So most often, if you do not have accuracy in your total cholesterol, in your triglyceride, and your HDL, you're going to get an erroneous LDL as well. So as you see, this TG divided by 5 is an important factor in the LDL cholesterol estimation. So you have certain exclusion factors for using this calculated LDL cholesterol, which is TG greater than 400, chylomicrons, and type 3 dyslipidemia. So the beta quant is the reference method for LDL is actually an ultracentrifugation method where you discard the supernatant, collect the infernatant, which has the LDL plus the HDL, and you measure using reagents. You measure the cholesterol in this fraction. You have the HDL in the supernatant. You measure the cholesterol, which is B, and your LDL cholesterol is actually this A, which is HDL plus LDL minus B. So again, this is the reference method for the LDL cholesterol. But you can also, in cases where you have hypertriglyceridemia, also use a direct LDL cholesterol assay, which is an immunoassay, where you have the patient sera and reagent are mixed. The reagent has ApoA1 and ApoE. So again, it's a process of elimination. If you take out your A1 and your E containing lipoproteins, which are your VLDL, IDL, and HDL, what is remaining is your LDL cholesterol. So again, it is an estimation. It's a measurement based on exclusion of the other lipoproteins. So we and other people have shown, many labs have shown that even in high triglyceride levels where you don't use the Friedewald equation, you have a pretty good index of your direct LDL cholesterol using this correlation of 0.97 and zero point 0.9 R value for your direct LDL cholesterol versus your beta quant LDL. Now, the gold standard, like I said, is the ultracentrifugation, and you have these chylomicrons, VLDL, IDL, and LDL. The problem in the ultracentrifugation technique is that you need, of course, an ultracentrifuge, which is not available in routine labs. And the problem is that each of the fractions have to be taken out. It's a 3-hour process and a 6-hour process after that to get your LDL cholesterol. So this is not ideal for routine LDL measurement, but for in research labs and in lipoprotein specific labs, this is how LDL is measured. You can also do without measurement. We can do a semi-quantitative LDL lipoprotein electrophoresis, and again, this is the tracing of a lipoprotein electrophoresis, you have your beta, your pre-beta, and alpha, which correlates to these fractions on the ultracentrifuge. Okay, so the Friedwald equation is the most common used for LDL measurements, but there are problems. We know that when the Friedwald equation was originally developed, it was developed on less than 500 samples, and it was not developed on the general population, but it was developed on patients with familial hypercholesterolemia. So there's a 1 to 5 ratio, right? So the equation assumes a fixed TG to cholesterol ratio to estimate the VLDL cholesterol, and therefore it's not valid at high levels of triglyceride. Now, in the area, we are now in the age of non-fasting, lipid profiles, and this you do need fasting samples for the Friedwald equation, since it leads to an underestimation of VLDL and overestimation of LDL. Also, it loses accuracy even at low levels of triglycerides as 150 milligrams per deciliter, or if your LDL is really very low. Now, with the direct LDL cholesterol assay, there are a lot of assays that are available from many vendors, but there is a lack of standardization across laboratories. And again, if your triglycerides, although it's over 400 milligrams per deciliter, your direct LDL cholesterol over 4.5 millimoles of hypertriglycerides kind of starts becoming less reliable. And there is a concern of the clinical utility of non-fasting samples, and the direct LDL cholesterol measurements are time consuming. Not only that, these are expensive assays, unlike the $5 or whatever it may equate to in different um, um, currencies. It's much cheaper than a direct LDL cholesterol assay. And if you just use the direct LDL for everybody, it would definitely be very cost prohibitive. So many equations have been derived based on a different triglyceride to cholesterol ratio. And these are all listed on this slide. And I'm not going to go through all of these except two equations which are most commonly used in clinical laboratories. So the first one is that came about was the Martin-Hopkins equation, and it uses patient-specific ratios of TG to LDL. You have a 180 cell table where you derive this, and I will show that to you on the next slide. And you also have the Sampson or the NIH equation, which uses TG and non-HDL cholesterol as an independent variable. So here are the equations that we are going to look at. So this is Martin-Hopkins LDL. It's a total cholesterol minus HDL times non-HDL minus cholesterol. So basically it's TC minus HDL is the non-HDL cholesterol. And then you have this triglycerides divided by an adjustable Norwell factor. This adjustable Norwell factor, and I know it's too small to see, but basically you have the non-HDL, the VLDL cholesterol derived based on different fractions of triglycerides. So you use this factor in this equation and you derive the Martin-Hopkins LDL equation. So as you see in a LIS, you have to actually build all of these 180 cell characters to be able to derive the LDL calculation from the Martin-Hopkins equation. And again, this is the NIH Sampson LDL calculation. It seems kind of rather complicated, but it actually uses the measurements that you would normally do on a lipid profile, which is total cholesterol, triglycerides, and HDL, right? So this equation, even though it looks complex, it has only these three measurements. You have the non-HDL cholesterol from the total cholesterol minus the HDL cholesterol, and you're able to derive the LDL from this equation. So the pros for the Martin-Hopkins equation is it's been validated in a really large data set in many different countries and many different populations. And it has improved classification for people who have really low LDL cholesterol, such as those on the novel LDL targets or the PCSK9 inhibitors. The cons, of course, are that it's a 180 cell equation, and it is not in widespread use because of the complexity of implementing this in a standard laboratory information system. Also, in a pediatric specialized population, it's not been shown to be very accurate. And the other one that's most popular is and adapted is the NIH Sampson equation. Again, this was formulated in patients where the TG levels were up to 9 millimoles per liter or 800 milligrams per deciliter. And the correlation was with the beta quantification. And so this equation is freely available online. And even though it's complicated, it's much more easily adaptable to the LIS, and therefore it's more practical. The cons, of course, are that it may underestimate LDL at low levels compared to the ultracentrifugation derived on a study set, which did not have many low LDL cholesterol levels. So this, both the Martin-Hopkins equation as well as the Sampson NIH calculations are very popular in terms of being very widely available in addition to your Friedwald LDL cholesterol. So LDL obviously is not just one protein, one lipoprotein. Just like all of the other lipoproteins, it's a continuum of different sizes. And here you have the different HDL fractions, and you also have the different LDL fractions, which include the risk factor Lp(a), which we're not going to talk about today. So here are the LDL subfractions. I'm not going to go into much detail, except that the core TG is variable. So when there's more, when it's more small dense LDL or triglyceride-rich particles, so you have your pattern B subfractions as well as your pattern A. The more pattern B, the worse off you are in terms of your risk. There are many methods for LDL subfractionation. Some of them don't exist anymore, like the Atherotech VAP, but it basically uses many different kinds. You have the polyacrylamide electrophoresis, you have NMR spectroscopy, and the most common being the gradient gel, as well as the LC mass spec methods now for fractionation of your LDL. So this is just to show that you have various fractions in your LDL that you can isolate using either electrophoresis or mass spec. So small dense LDL, again, you have, we talked about the amount of cholesterol within the smaller LDL particles. They stay longer in the circulation. They are more atherogenic. So it's a good measure of your atherogenic index to measure small dense LDL cholesterol. And you do have immunoassays. I also wanted to say that in prediabetes or in metabolic syndrome, you have small dense LDL where you have high triglyceride and low HDL. You have increased amounts of small dense LDL, which confer increased risk. And you do have an automated homogeneous immunoassay to measure small dense LDL, which are now available in platforms like the Roche platform. So we have LDL cholesterol, different ranges. You have different targets for small dense LDL. You have different targets for your LDL particles. And I know I'm kind of exceeding time, but I'm going to finish off really quick. So this is a paper that shows that from Martins et al., which was very recent last year, which shows that LDL calculation, Martin, Hopkins, and Sampson, which are all calculations, are for routine use. Direct LDL are for patients with high triglycerides. And in a patient where you want to assess the atherosclerotic risk based on the LDL particles, you can also measure LDL particles as well as small dense LDL. And there are also assays under development on the mass spec where you can derive where you can accurately measure your different LDL fractions. So there are pre-analytical considerations to go through, such as posture, exercise, diet, smoking, drugs, etc. For a lipid profile in a patient where you need to address the lipid disorder, fasting is preferred. But for screening, I think the Nordistrad and several studies from different parts of the world have shown that fasting is really not required to screen for lipids. And the only big change that you see is obviously in the triglyceride levels, but not really that much change in all of the other lipid parameters. You do have other secondary disorders of hypercholesterolemia and hypertriglyceridemia. Those have to be assessed when one is treating a lipid disorder. And so this, again, is from the Martins et al. Paper, where you have the cardiovascular risk algorithm based on lipid parameter concentrations and the Framingham risk score. I don't know if it is really, you can see this very well, but basically it starts off where you're doing a basic lipids, which is your total cholesterol, triglyceride, and HDL, and calculating your non-HDL cholesterol. If your triglycerides is low and it's a non-fasted sample, then it's fine, it's acceptable. If the TG is greater than 2 millimolar, then you use the either the Martin-Hopkins equation or the Sampson equation and do the advanced lipid profile. Now, if your TG is high, of course, what is most preferred is your fasting sample, preferably at least 9 to 12 hours of fasting. And if your triglycerides are still high, then you can either request a direct LDL measurement, because there are problems to the other equations, or you can do if you have the opportunity to do a reference method for LDL, which is the beta quant method, you can do that. So I'm not going to go into the primary prevention and the secondary prevention studies, but there are goals for LDL cholesterol, ApoB, as well as non-HDL cholesterol, and in secondary prevention, also triglycerides. And these are all important derived lipid parameters that we as a lab have to measure accurately in order for the physician or the lipidologist to treat the lipid disorder. So I think I am running out of time, but just to say it's a continuum. So the earlier that you pick it up, the better for healthcare of this particular patient and cardiovascular risk. I will stop here. It's time for my coffee for sure in the US. So I will stop here and we'll take questions at the end.
Thank you very much, Dr. Devraj. Our next speaker is from Ireland, University College Dublin. It's Patrick Toomey. He's a consultant chemical pathologist at St. Vincent's University Hospital in Dublin, and the laboratory director for clinical chemistry at St. Vincent's Hospital at University College Dublin. And he will be talking about risk assessment in cardiovascular disease and how to use these derived lipid parameters. Dr. Toomey.
Thank you very much, Tahir. And I now just need to make sure I can get the my controls in order. So I'm both excellent, good, both a lipidologist, so I'm practicing patients, and obviously laboratory background. So as Sridevi mentioned, Framingham plays a very important part in lipid studies and lipidology. And what people don't realize is before the Second World War, they knew that there was an epidemic of cardiovascular disease coming down the tracks. Unfortunately, delayed. And when they went ahead in Framingham in Massachusetts, they just measured total cholesterol. They had issues with the HDL assay, and they realized that actually there's much more than just cholesterol. When they eventually measured HDL as well, the picture started to become more clear that it wasn't just total cholesterol. That the phrase that I like is the good, the bad, and the ugly. And I still don't have control. So next, let me just see. Do I need to put on? Maybe I'll screen share. Do I? Oh, okay, yeah, they're getting on. Anyway, the equation is on the left, and I dream about this. And well, some people say it's a nightmare, but it's a much easier form of looking at it, and a very good patient tool is the red, amber, green approach on the right. But this is probably the first ever use, unknowns to most people, of a derived lipid profile, or a derived value in lipidology. And so it's the total cholesterol, the HDL cholesterol ratio. And as you can see, as that ratio increases, you will see, irrespective of what the population is, male, female, smokers, non-smokers, people with diabetes, people without diabetes, you go from lower ratios to higher ratios, you go from green to amber to red. Now, and I am, yeah, excellent. So Fredrickson, in the subsequently after Framingham, came up with a huge number of chapters, in effect, published in the New England Journal of Medicine about lipoproteins and lipids, and we all look at it in a much simpler way of based on total cholesterol, triglycerides, and other values. Now, I'm sorry. Now, I am cloud slides. I must apologize. I was able to listen to rehearsals very well, and excellent. I can get good. Irrespective of that, as Sri Devi mentioned, statins came along, and the whole way of treating lipids changed immensely. Up till then, you were talking of much smaller reductions in LDL cholesterol. The most successful study actually was a non-lipid lowering agent, and that's the POSH study, which was a partial ileal bypass in familial hypercholesterolemia patients. Statins changed everything, and as you can see, the higher doses of rosuvastatin, you're achieving over 50% LDL reductions. So everything seems to be emphasis on evidence-based medicine and statins, and the whole lipidology, in a kind of roundabout way, was reduced to LDL, unfortunately. Now, I've borrowed this from a slide deck of previous, that our chair previously used, and Sri Devi's gone into this, and also back to evidence-based medicine, which studies actually use beta quantification. And the answer is not a lot, not many, some of the initial studies, but not many of the recent studies. Now, there's a good reason for this: more expensive, not used in the routine world. There was a whole floor in the lab buildings in Glasgow for the west of Scotland. It was reportedly said that that floor wobbled a bit when the study, when they were analysing further studies. But like that, there are limitations with the Friedewald equation, not just fasting, but also the picking up of type 3 dyslipidemia. But all the cases I'm using later on are based on Friedewald, because that's what the vast majority of the world actually uses, but it is changing. So in practice, again, it varies. It's a very heterogeneous practice around the world. Unfortunately, I still know some cardiologists who just request total cholesterol. I wish they didn't, but that's what they do. Others will do total cholesterol and triglycerides. I know a lot of primary care physicians have difficulty with triglycerides, so they quite like total cholesterol and HDL cholesterol only as a profile. Some like total cholesterol, HDL, and triglycerides, and obviously you can calculate other things as a result. And then some approaches are ApoB, ApoA1, and LPA. So there is a lot of heterogeneity around the world. Labs do try and standardize that and have their own particular profile, and it can as well depend on what insurance systems offer, or similarly universal coverage. So that then, obviously, depending what's measured, then goes on to say what you can derive in practice. So quite common in the UK and other parts of the world is the following on from Framingham is the total cholesterol, the HDL cholesterol ratio. All aware, and it doesn't matter which equation you use, but calculated LDL cholesterol. Then non-HDL cholesterol, very simple, total cholesterol minus HDL cholesterol. And then the ApoB, ApoA1 ratio, again used in some countries. And then the total cholesterol ApoB ratio, or the more updated since 2019, non-HDL to ApoB ratio, and then triglycerides divided by ApoB. Now, all this depends on what you can, what you have available to you, and how specialized you are as well at and comfortable at interpreting these results. They all have different uses, and so total cholesterol to HDL ratio is not something I would generally use in secondary prevention, and similarly, I would not think many people would use the ApoB, ApoA1 in secondary prevention. That is those with vascular disease. It's all about preventing those who have in the first place, or so-called primary prevention. Similarly, the total cholesterol to ApoB and the non-HDL to ApoB is very good for classification and investigation of hypertriglyceridemia, and similarly with the triglycerides divided by the ApoB. So if you don't have hypertriglyceridemia, then this is much less valuable or interesting. And personally, I don't tend to look at those in patients who don't have hypertriglyceridemia. And then you have calculated LDL cholesterol and non-HDL cholesterol in treatment to target. So if someone is being treated with a statin or other lipid-lowering agent, then how well are they responding to that treatment? And so the nice guidance in the UK is that you are expecting a 40% non-HDL cholesterol reduction. So you set a target of 60% and wanting to get below that. Or for those with familial hypercholesterolemia, you want to get a reduction of 50% in the peak LDL cholesterol, which is easier to calculate and mentally much easier to review when looking at results. So all these factors or parameters, derived parameters, have pros and cons, advantages and disadvantages. Some obviously are where the triglyceride concentration doesn't matter, some where it does matter, and then evidence-based or familiarity or historical. So if you are doing random cholesterol or lipid profiles, then the triglycerides concentration can matter in those parameters. And so calculate LDL and triglycerides divided by ApoB. Of course, with the ApoB in as well, there is you need it before you start treatment. And that's one of the disadvantages of any ApoB approach. It's before you start any treatment. Now, I like to put a local perspective on things, and in Ireland, our accreditation body is the Irish National Accreditation Body. And so they, amongst other ISO, they assess us on 15189 for medical laboratories, and they have a policy on calculated methods. And it's very, very reasonable, but it's also bearing in mind anyone can produce a calculation. They don't have to be in the laboratory. It is how robust it is. Have they verified the data using an independent data set, for example? Have they even calculated correctly? It is known, you'll see from external quality assurance or proficiency testing, that people are using the Friedewald equation, but still reporting when the triglycerides are above 4.5 millimoles per liter. So it's it just because there is an equation doesn't mean it's used appropriately. This is so what the Irish standards are, or the Irish interpretation of the standards are, is that you have to use IQC, for example. And here's just some data from an international producer of IQC, and you can see they have a different value for calculated than non-calculated. I would assume, but you shouldn't never make any assumptions, that this is the Friedwald, and that again we will see greater differences on this as the newer equations come more into practice. Similarly, this is an international proficiency testing data, or EQA, and I like this is one of the returns that I've come across in the past. And what you can see is that the individual analyses are fine, but the derived parameters are starting to be outside where you want to be. They're only in the between 1 and 2 standard deviations, but you can never make assumptions that that your derived parameter is performing okay just because the original baseline assays are performing okay. More interesting, and so the bottom 2 slides here are for non-HDL and calculated LDL cholesterol. Is the more individual parameters in the calculation, the greater the CV and the standard deviation. In simple terms, the greater the spread of the data. So that's something to bear in mind. Medicine isn't static; it's changing, whether correctly or not so correctly. More emphasis on investigations, less emphasis on history and examinations. Unfortunately, there are fewer signs of dyslipidemia nowadays at clinics than at lipid clinics than when I started practicing. There are newer medicines. There are now increased availability of genetic testing, and actually I'm happier to go genetic testing is more reliable and reproducible than and mean more than signs of dyslipidemia, for example. And then you telemedicine. So I do a lot of virtual clinics, and I do much fewer face-to-face clinics. So, as well as the change, there are 2 publications I want to highlight. This is the Sampson and Remily group, which are the same group that came up with the Sampson equation, and they have their phenotypical classification. And so it's quite easy and pragmatic to use, and I like using it. At the bottom right, depending on what the concentrations for triglycerides and non-HDL cholesterol are, it doesn't pick up type 3 as they state. But even more before that was the diagnostic algorithm for atherogenic apolipoprotein B dyslipoproteinemias, which is a mouthful. I'm glad it's not later in the day like Andrew for this presentation. And that's from the Alan Schneiderman's group, and this is a algorithm to follow, which looks more complex than it is, but is quite good because it gives you both the primary and secondary, the inherited and the secondary causes of dyslipidemia, and depending. And so again, quite simple, whether you have a raised triglyceride or not. If you have a raised, you stick to the left. If you don't, you stick to the right, and so forth. And then there's the breakdown depending on various derived. So to go through that, I'm just going to go some clinical cases in practice. And I see I don't have much time, so I will quickly go through those. And as I said, all based on the Friedwald. So, because this is an international presentation, I've got the results both in what I consider the proper SI units, millimoles per liter, and also on the left, and milligrams per deciliter. And so this case, all these cases I've seen at clinic, the main issue, so it's a mixed dyslipidemia with quite a raised total cholesterol and triglycerides. And not surprisingly, no calculated LDL, a very high ratio total cholesterol to HDL, again, as expected, and a raised non-HDL cholesterol. And what you'll see is they were first put on a low dose of fenofibrate, and then atorvastatin added in, and their non-HDL came down and the ratio came down. Okay. So When you look at the Samson classification, it's type 5, and when you go through the history as well, the requester believes that it is genetic, and they've got quite a relevant family history. So we did our usual studies, apolipoproteins. We also did genetic, while quite unlikely to have genetic FH. Data coming out of Spain in particular shows you will find a not insignificant number will have genetic familial hypercholesterolemia, but we also did a SNP score and nothing major showed up. But interesting, the non-HDL to ApoB ratio was raised. Now, I haven't provided the reference for this. It's Neely 2019 in clinical chemistry, and Alan Schneiderman did a ratio because they suggested replacing the total cholesterol to ApoB ratio with the non-HDL to ApoB. And the best cutoff they found was 4.91. And so any results that I come across with mixed dyslipidemia, that the ratio is above of non-HDL to ApoB is above 4.91, we send for ApoE2 genetics. And lo and behold, it came back positive. And we have quite a high pickup rate, and we now have, I think it's 9 or 10 patients in a small enough catchment area of less than 250,000 population that have E2E2. So that's one of the ways that the ratio is helping to pick up, and much better than looking for orange PAM or creases on clinical examination. So in this case, actually cascade screening, looking back at the family history, the brother probably also has type 3, and siblings would have a 1 in 4 risk. Good. When you look through the Schneiderman algorithm, and again using the various ratios, you do come down to a similar picture. And this is where the Schneiderman algorithm and derived ratios is quite good. And I do, for those who are not aware of it, I do suggest that you look this up. It is a little bit more complex, but it is quite comprehensive. What you will also see, though, is that there are overlaps in the secondary causes, and so it's quite helpful. And clinically, it's good to work back and see actually have you potentially missed something or not. Okay, so next. Where the derived factors are also quite good is when there is a significant difference between the non-HDL and the LDL. And it's usually of the order of about 0.8 millimoles per liter. The Canadians have gone into more detail and say 0.6 to 0.8. And what you'll see is when the triglycerides are greater, about 1.5, some say 2, but of that order, you will start seeing divergence. Especially at low LDL cholesterols. And so in individual patients, I look at the difference between the two and see. Furthermore, when you look at, so the previous slide was within the same patient, within different patients as well. What you will see is that the younger, so we will have many patients with familial hypercholesterolemia who have been brought up because their parents had familial hypercholesterolemia with excellent lifestyles, be it diet, activity, and so forth. And they will have a much smaller difference in the non-HDL and the LDL, definitely Friedwald, but even others. And those who are higher BMIs, diabetes, higher triglycerides will have a greater difference. So it gives you some quite interesting insights. So with that, in summary, LDL cholesterol has the strongest treatment evidence-based, and obviously that's derived. Lipidology is not all about LDL. Derived lipid profile parameters have various uses, but we need to be aware of their limitations, and that means looking at IQC, EQA, and that they have greater SDs and CVs. And ApoB ideally needs to be measured before treatment commences. Thank you very much, and I'm happy later on Tahir, you'll direct us about any questions.
Thank you very much. And so that's a very nice segue into ApoB. Our next speaker is Andrew Dunwakop. He's based in Sydney at the moment, but he's a professor in pathology and molecular medicine at McMaster University in Hamilton. You can go ahead, Andrew.
Okay, thanks Tahir, and I look forward to sort of firming up on a few of the things that have been said already. So no disclosures for this one, but I have used ApoB and especially lipid clinic for a number of years, and just some two learning objectives. But I'll go through really just presenting the two, looking at the advantages of either ApoB or LDL cholesterol, and in that context, you'll get the limitations of both as well. I think this has already been covered by Professor Devaraj. But what's important in the biology side of this is that there's a single lipoprotein B molecule associated with this spectrum of the atherogenic lipoprotein, so not the HDL cholesterol, but VLDL, IDL, LDL, and lipoprotein little a. And there is also an ApoB48 on the chylomicron remnant. So there is apolipoprotein B across the full spectrum of particles, and this is then becomes a really good indicator of the number of particles you have. The LDL cholesterol, and methods have been described already, looks at the portion, only a portion of the atherogenic lipoproteins. It is the biggest portion. This is the figure there is taken also from one of Dr. Snyderman's papers, where he looked at apolipoprotein B. This one is to try and describe the proportion of ApoB containing particles. And so you can see that LDL is the bulk of them, and in the LDL there's the multiple sizes. So you've got the small dense LDL and the larger LDL particles, and then there's also lipoprotein A that's a contributor to the total amount of apolipoprotein B. So from a biological perspective, for the atherogenic lipoproteins, ApoB is a good marker. And so I'm going to put these slides up as we go through the presentation. So in this particular case, LDL cholesterol represents a portion of the atherogenic lipoproteins, whereas ApoB is representative of all the atherogenic cholesterol. The laboratory measurements have also been described already, but I'll go through these again. So we have direct LDL cholesterol, the calculated LDL cholesterol, and apolipoprotein B. They are methods available for direct LDL cholesterol and that has been described already. Just bear in mind that the variability in that one comes from time and composition of last meals or last fluid intake. The triglyceride levels have a role in that, and the HDL cholesterol, because remember, you're precipitating out the HDL as part of the measurement. And if you've got a lot of lipoprotein A, that also influences the direct LDL cholesterol measurements. The calculated LDL cholesterols are based on calculations from total cholesterol, HDL cholesterol, and triglycerides, and have the same influences from triglyceride levels and high lipoprotein A, and the meal and the food consumption, and liquid consumption. So those are sort of the sources of variability for those two measures. For apolipoprotein B, you've got two main methods in use at the moment would be immunoturbidimetric methods and then inflammatory methods. There are older ELISA methods available, which maybe some people are still using. And so because these all have antibody interactions, there's more of the immunoassay type variability that you get between methods. And with an inflammatory, with higher triglycerides, so typically quite a bit higher than what influences the LDL cholesterol measurement or the LDL cholesterol calculations, but you can get some interference with the inflammatory methods with very high triglycerides. This particular table was adapted from a paper published in the Journal of Clinical Lipidology in 2021, and the references there. And they took data from the College of American Pathologists external proficiency testing samples, and they came up with these bias and precision and total error calculations from that data from College of American Pathologists. And you can see that there's a bias on the direct LDL cholesterol measurements, which is not too bad, around 6%, precision around 5%, with a total error of around 14%. The ApoB, they came up with quite a wide range in bias, from minus 27% to plus 11%, so a big range in the bias with poor precision, and the calculated LDL cholesterols looked pretty good from a bias and precision perspective. I took the liberty to talk to Dr. Hubert Vesper, who works at the CDC standardization program, and he pointed me to the College of American Pathologists accuracy-based lipids program, and to a educational discussion article that he had written in 2019 based on a 2019 survey. So again, the reference is at the bottom of the slide there. It is available. And so when he looked at the accuracy-based lipid program, and he runs the accuracy target setup in his laboratory at the CDC, you get a slightly different picture. And in this particular one, he was highlighting the fact that the higher triglyceride levels in 2 of the 3 samples had really influenced the direct LDL cholesterol measurements, as well as the calculated LDL cholesterol measurements. And so the bias in that was more significant than maybe had been previously thought. So here we see that the actual bias for the direct LDL cholesterol is around 4.8%. ApoB came out in this particular one at minus 1.2%. Calculated LDL cholesterol minus 1.8%. So reasonably good bias on all of these methods. The direct LDL cholesterol was not as good in this particular set of results, largely because of these high triglycerides, the high level of triglycerides in 2 of the 3 samples. The precision was good for direct LDL cholesterol at about 3.3%, CVs, and the calculated LDL cholesterol around 4% precision based on CV percentage. I've put the ApoB wasn't actually calculated in the report that he shared on that website, and the discussion that he put in there, but it is estimated at about 5% from that data and from additional data I've got from the CDC laboratory. So Dr. Alicia Lyle from the CDC did provide me with this slide. She gave a presentation at the ADLM meeting where she'd gone through some of this data in more detail, and part of the presentation had ApoB in it, so I'd asked her for an updated slide. The lipid standardization program at the CDC has moved from an immunoassay-based reference value for apolipoprotein B to a mass spec-based reference value, and I'll discuss that on my next slide in a little bit more detail. But in panel A, you're looking at the nephelometric methods, and in panel B, the immunoturbidimetric methods. And you can see as the move between 2020 and 2023, they switched over from the immunoassay-based reference value to a mass spec-based reference value. And for ApoB, which is the lower box and whisker plots, you can see that the ApoB is moving closer to the target, the 0 point, and particularly on the immunoturbidimetric methods, with the nephelometric methods still showing a slight negative bias, but the precision is also improving in those, and the boxes are tightening up. So it looks like there's some improvement with the performance of the methods when you start using a mass spec-based reference value for the target. So the other important aspect of lipid measurements is standardization, and so here I just wanted to point out some of the differences. So the direct LDL cholesterol is an indirect reference standard, because really what you're measuring is the reference method is the CDC reference laboratory ultracentrifugation method. It's been described, and so you're measuring other measurements within the ultracentrifugated sample. And so it's not really a direct measurement, it's an indirect measurement, but it is quite a well-maintained method. It is a reference method, and it has been in place for a good number of years. And so it comes up as a pretty good reference method with an indirect reference standard. There's acceptable precision targets of 4%, and allowable bias is 4% as well. The apolipoprotein B, there's been a reference standard that's been around for a good number of years. It was published in 1994 in a clinical chemistry paper, and so that's available and it has been used. It's based on an immunoassay-based measurement of a specific apolipoprotein B reference material. So that is available. There's a reference method that was first published in 1989, but there's a new method in progress based on LC mass spec detection, and this is published in 2021 in clinical chemistry, and this is the method that is being used in the CDC standardization program at the moment. It still hasn't been fully accepted as a reference method, but is good progress towards that, supported by the IFCC and a number of labs in the network that support the lipid standardization. Unfortunately, there's not acceptable precision targets or allowable bias set for apolipoprotein B, so that is a missing piece. But as I've shown you, the precision on the previous slide is pretty good, and the allowable bias is around 5%, so not that different to direct LDL cholesterol measurements. With the calculated LDL cholesterol, the reference standard is the certification program and based through the CDC lipid standardization program. The reference method is available, but it's based on total cholesterol, HDL cholesterol, and triglyceride measurements because they're calculated, and then the individual precision and allowable bias targets are reported there. But for the calculated LDL cholesterol, the same precision targets of 4% are put down for both direct and calculated LDL cholesterol. So that information is there. So when you add these factors in, and so I've talked about a few things. So the positive side, or the pro for the LDL cholesterol, is the better overall precision due to the standardization program for lipids. And this has been running, I think, close to 30 to 40 years now. And so it's really has done a lot to standardize the standard total cholesterol, triglyceride, and HDL cholesterol measurements that we have. And Professor Toomey did go through the history behind that and some of those factors. With ApoB, there's a higher chance of getting a traceability with a reference standard and a reference method. Because we've had a reference standard for a long time, there's a new reference standard also in production and a new reference method. But because those pieces sit in place, and because it's a very standardized protein, it's much easier to come up with these traceability aspects. And so with that, we should get improvement in the precision and accuracy of the methods that are available for apolipoprotein B. And then the other piece that Dr. Vesper pointed out to me was this, the improved accuracy in the high triglyceride samples. And that's been alluded to by both previous speakers as well, is that you've got, with the LDL cholesterol, because of the influence of triglycerides in the calculations and in the way that you actually do the beta quantification or the direct measurements, the apolipoprotein B does give you a more accurate result in high triglyceride samples. So again, so some pros for apolipoprotein B and one now for the LDL cholesterol. The availability of these methods, it's very apparent from both previous presentations that calculated LDL cholesterol is what most people will get access to. And Professor Toomey also described there's a lot of variability in practice in different parts of the world, but most laboratories can offer a total cholesterol, a triglyceride, and an HDL cholesterol. Most of these methods worldwide are harmonized to the CDC lipid standardization program through the manufacturers who comply with that. And then, as has already been mentioned, the Friedewald equation is the most widely used, but there are a number of other equations available to calculate LDL cholesterol. It will be interesting to see whether the consistency we get with the calculated LDL cholesterol changes over time with use of the more common use of other calculations in some areas now. But that's something to be observed going forward. So direct LDL cholesterol is available on numerous instruments. There's a bias between methods that was also pointed out by Professor Derived earlier. And again, it's impacted by high triglycerides. So that's a bit about the direct LDL cholesterol, but it is available. And in the United States, it has been quite widely used for high triglyceride samples, which may be something that people there's evidence to support that has been shown in the previous presentation, but again, on the higher triglycerides, it is impacted. Apolipoprotein B is available in a range of instruments, both nephelometric and immunoturbidimetric, which are fairly commonly, the immunoturbidimetrics are very common in our clinical practice. And with these, there is bias between methods. But as I've alluded to, with the better standardization program available for apolipoprotein B, this bias will hopefully reduce over time. So when you go back to just comparing the two, calculated LDL cholesterol is most available, so that's certainly a pro for LDL cholesterol. I'm going to give you a little bit of information on cardiovascular disease outcomes. Hopefully this is large enough for people to see, but this slide is taken from a meta-analysis that was published in 2012, and it is focused on the statin trials, so people who were put on statins or randomized to statins or placebo. So there's a number of trials that were included in this meta-analysis. So there's 7 trials in this meta-analysis. And if you look at I'm not sure if you can see the pointer, but if you look at the overall scores, where you have about 5,000 odd cardiovascular events and 38,000 participants, the very top box for in the first column is low density lipoprotein cholesterol, and that you can see is the hazard ratio is above 1. There's quite nice tight error bars around that. But if you look at apolipoprotein B across on the right, it's very similar. It's very similar values, also quite a tight distribution. Individual studies obviously have a slightly wider spread, but apolipoprotein B in most of those studies also demonstrated a significant hazard ratio for the detection of major cardiovascular events stratified. And again, this has been stratified by the study. So the hazard ratios for LDL cholesterol and apolipoprotein B are pretty similar in this meta-analysis, which was published in 2012. So that's just summarized in the top line there. So there's 8 trials, 62,000 participants, and 38,000 were allocated to statin therapy. And if you look at the details in there, there was no significant difference between the apolipoprotein B and LDL cholesterol for major cardiovascular events. So this particular meta-analysis was critiqued by one other group that decided to do a second meta-analysis, but using different statistical approaches, and they used frequentist and Bayesian meta-analysis calculations. They included 7 trials, so they added HPS, which was a big trial, and removed TNT and IDEAL from the previous table that I've shown you. So there's a lot of overlap in the trials that they used, and these were all statin to placebo trials. They used this alternative statistical approach, looking at risk reduction across the trials, and they determined that the risk reduction was more closely related to reductions in apolipoprotein B than reductions to either non-HDL cholesterol or LDL cholesterol. And in the paper, they demonstrate the significant p-values for this risk reduction. So again, that was published in 2014, and to note that I think Dr. Snyderman was part of that group that published that paper as well. Right, so if you're looking at, so in this particular slide, I've made no changes because I think from those 2 meta-analyses, there's certainly equivalence in determining major cardiovascular events with either LDL cholesterol or apolipoprotein B. There might be in the second one some slight improvements with apolipoprotein B, but still really good ability to pick up major cardiovascular events. So I haven't given that as a pro to either one because I think they both work very well in that context. In the last number of years, we've been seeing more intensive lipid lowering using PCSK9 inhibitors particularly, and a little bit before that, ezetimibe was also used with statins. And so another group have done not a full meta-analysis, but they've taken 3 trials, or 3 populations, 2 prospective randomized controlled trials. One was using a PCSK9 inhibitor with the statin, and the other was ezetimibe with the statin. So both these populations were on a statin, and they were randomized in the trials to PCSK9 inhibitor or placebo, or ezetimibe and placebo, but they were all on a statin. So they had over 40,000 statin-treated individuals in secondary prevention trials. And then they took data from the UK Biobank study as a primary prevention comparator, in that they had about nearly 390,000 primary prevention with people with no lipid-lowering treatment at entry and no established cardiovascular disease at entry. They did measure apolipoprotein B, and LDL cholesterol was calculated in most occasions, but measured as a direct LDL cholesterol under certain parameters. So the high triglycerides as one example. And then they were looking at, in this particular report, they looked at endpoint fatal or non-fatal myocardial infarct, so not the full range of vascular disease outcomes or the heart-related disease outcomes, but specifically myocardial infarct, which is an easier one to pick up out of databases and so on. Unfortunately, one of the weaknesses of the study is that they didn't actually report in the paper the absolute endpoint numbers for each of the individual populations, which I think is a bit of a disadvantage. They could have easily put that in. The data is available in the primary studies. And so in this particular one, there's 4 panels that you can see here. The top one is A and B, or the primary prevention studies. The first one is clinically adjusted, and that was for all the typical sort of clinical parameters, including height, weight, age, gender, smoking status, hypertension, diabetes, ethnicity, kidney function, etc. So all those sorts of things were included in the clinically adjusted models, and they looked at hazard ratios. And then the second one, they adjusted for lipid parameters, which was non-HDL cholesterol, triglycerides, and HDL cholesterol, in addition to the clinical variables. ApoB is the top box, and you can see that just on the clinically adjusted, ApoB and non-HDL cholesterol perform pretty close to each other in the hazard ratios. But once you actually correct for some of the lipid parameters in the primary prevention population, the apolipoprotein B does perform a little bit better to estimate the hazard ratio for developing a myocardial infarct. If you look at the secondary prevention group, which is panel C and D, the similar findings. The hazard ratio is, again, pretty good for both ApoB and non-HDL cholesterol in the clinically adjusted model. And then when you add in the lipid parameters, the ApoB sort of improves a little bit more than the non-HDL cholesterol. So this is quite interesting, but it certainly, to me, points to the fact that your atherogenic particles, which we know from biology, which are related to ApoB, are certainly, those ApoB measurements are then predicting myocardial infarct better through these sort of models that are built through this clinical trial data. So in this case, I will add that, in my opinion, the apolipoprotein B is a better predictor of myocardial infarction than LDL cholesterol. The next piece I wanted to touch on was the clinical practice guidelines, and these have also been already discussed by the previous presenters, but just really to point out here in this slide, which sort of summarizes the components that I'm talking about today. So LDL cholesterol is recommended, and I've looked at 3, so the Canadian, the European, and the US guidelines, and I've put a more recent National Lipid Association recommendation up as well. But all of them recommend LDL cholesterol as a screening and the treatment, and using it for treatment targets. The European and the US also have some disease-specific cut points for LDL cholesterol, and the National Lipid Association recommended LDL cholesterol for screening and treatment monitoring. So LDL cholesterol has certainly got a very prominent role in clinical practice guidelines, and that is based on the big statin trials, the trials of the newer drugs, and a lot of our sort of general knowledge around how LDL cholesterol has influenced our clinical practice over the last 20 to 30 years. Apolipoprotein B has got a pretty good status in the Canadian guideline, where it is recommended for screening, and it's the preferred method for screening if your triglyceride is greater than 1.5 millimoles per liter. And Professor Toomey did mention that in his presentation. They also provide treatment targets for apolipoprotein B in the Canadian guideline. The European guideline talks about the use of apolipoprotein B in screening, and specifically in specific situations, and they mention people with high triglycerides, people with diabetes, and people with obesity. So they have 3 categories of people, which does cover a fair amount, proportion of our populations. They do recommend that apolipoprotein B could be used in those to avoid the difficulties you have with high triglyceride in the calculated LDL cholesterol or the direct measurement of LDL cholesterol. And then they provide targets for treatment as well, which they say you can use. The US guidelines aren't as positive about the use of apolipoprotein B. They say it can be used as a risk enhancer in the screening process. So once you've done your lipid profile, if you want to add on risk enhancers, they have a couple of tests that you can do for using as a risk enhancer, and apolipoprotein B is there as an estimate of the particle size and the number of particles, of atherogenic particles that you have. So it is mentioned in that context. And they also say it can be used in specific situations such as high triglycerides. And then the National Lipid Association just talked about facilitating diagnosis of certain familial dyslipidemias. And Professor Toomey has shown you those nice charts that do help with separating between the familial dyslipidemias. And it can be a reasonable initial evaluation tool, and it can be used for treatment monitoring, but it's not the recommended test. So if you're adding that to the pros, certainly LDL cholesterol has many more clinical practice guideline recommendations. So that is the pro for LDL cholesterol. So just to summarize, and again, this is my opinion, ApoB has more pros than LDL cholesterol. I think it is a more accurate measurement than direct LDL cholesterol. It's further along the pathway to standardization, which should lead to a better availability or better utility of the testing in clinical practice, and better around the standardized cut points that are recommended in the clinical practice guidelines. It also reflects atherosclerotic disease pathophysiology more appropriately than some of the other measurements, and is a better predictor of myocardial infarct. On the other side, calculated LDL cholesterol is way more accessible. It's better harmonized because of the long-standing CDC lipid standardization program, and it is better acknowledged and recognized through clinical practice recommendations. So thank you, and we can probably get everyone together now for answering some of the questions.
Thank you very much, Professor Dan Walkup. I should point out that it's actually past midnight for him, so he's done put on a very brave effort. We can go to the questions now. I'm not seeing presenters. Are you all? I think we still have your last slide showing at the moment. Oh, there we go. Yeah. Okay. So we'll look at. We've got about 15 minutes for questions. I'll look at the ones that have been sent in. So we've got Chessie Voma, who is asking a question if there's any correlation between ApoB and lipoprotein little a. I don't know who would like to answer that.
So the lipoprotein A has an ApoB attached to it, and so that's part of the apolipoprotein B total measurement. But lipoprotein A is a complex molecule. It has a whole lot of other biology behind it, and there are obviously certain families that have very high lipoprotein A. It's a very hereditary sort of associated molecule. So there's not I wouldn't say there's a direct relationship, but ApoB is part of the lipoprotein A. I don't know if anyone else wants to add anything to that.
Yeah, I think in terms of cardiovascular risk, that depending on the patient, you would either measure ApoB or ApoB plus Lp(a).
Yeah.
Okay, we'll go on to the next. From a
pragmatic point of view, I tend to measure both anyway the first time and take it from there.
Yeah.
Yeah.
So somebody's asking about the cutoff for non-fasting HDL. That went away. HDL. Non-HDL is always 30 milligrams over your LDL, whatever your LDL target is. I don't know which one to answer because the questions keep going away.
Okay, I'm looking at the priority box. So if I started with those, Rudolf Gasco from Central Laboratory is asking about if evidence-based medicine shows that directly measured LDL cholesterol is not harmonized and at the same time, LDL cholesterol calculated by Sampson or Martin Hopkins is sufficiently accurate compared to the gold standard method, why is direct LDL still used in clinical practice? Who would like to answer that?
Well, I'll say I don't use direct LDL in the first place.
Yeah.
And if we were to change, it'll be to one of the two other derived, the Sampson or the Martin Hopkins. In fact, both at the AACC this year, both said that they're, irrespective of what they might think of each other's equations, they both think they're better than direct LDL. So
I would say that the direct LDL is not accurate in those patients with low HDL cholesterol, low LDL cholesterol. So these equations appear to be better. And the second thing would be that if you don't have universal health care and you can pay for whatever, then I guess they do all of it, including the direct LDL cholesterol measurement.
Yeah, I think also there's an assumption amongst people that if you're measuring something, it's more accurate than what's calculated. So there's, just a very empirical assumption that people may be making, and actually that's and if they don't understand the nuances between those, yeah. So,
I just want to add one thing there, because a lot of people also do their calculations against a direct LDL cholesterol. So when they derive their calculation, they're deriving it against a weak substitute for the beta quantification. So if the calculation is not derived against a beta quantification, it's probably not worth changing to that calculation.
Yes, that's true, and I think it's people there have been quite a few publications using that kind of method to compare, but you're absolutely right. Having beta quant is definitely going to give you the most accurate answer, and I think
And I think the next question has already been answered, the difference between calculated LDL using the Friedewald versus directly measuring LDL levels.
Yes.
And as regards to dietary fats, it's we're encouraging more monosaturated and polysaturated and less saturated. So it's more saturated fats for LDL, and so as a general rule.
Mm-hmm.
And genetics LDL.
Go ahead, Pat.
Yeah. So from familial hypercholesterolemia, again, so Andrew and I used to share an office, and back in the day, it was LDL receptor and ApoB perhaps, and then so we were working in this area before the PCSK9 was even discovered molecule. So now PCSK9, and so also autosomal codominant would be some ApoE, but not many. But the vast majority would be So for genetic familial hypercholesterolemia will be LDL, some ApoB. But then more and more emphasis on polygenic, because a lot of the patients I will see, when I had the polygenic score, they wouldn't have genetic familial hypercholesterolemia, but using a 12 SNP polygenic score, a lot would have, not all, but a lot would have high likelihood of polygenic. Unfortunately, I don't have that available to me anymore. So there's both but the higher risk is with genetic FH, and I think it's been calculated that polygenic only adds 30% extra to risk of that order. Mm-hmm. So it's much smaller than the genetic familial hypercholesterolemia.
We have Dolman asking about, is using ApoB not a better and simpler way to estimate CVD risk? I would say better, yes, for sure, because it talks about all of the atherogenic lipoproteins. But I don't know if it's a simpler way, because ApoB, you do need to have instrument to measure ApoB, and not all routine clinical labs that do measure lipid profiles. And you also have point of care lipids, but it's not a simpler way, but it definitely is a better way.
So yeah, just one other point is that a lot of the risk calculators don't have ApoB available in them. Some of them do. Where they do, that makes it simpler to use it if you can actually get it measured. So there's two parts to making it simple. Is it available, and is it in a risk calculator that you can actually easily access?
Why is the ultracentrifugation method the gold standard? Because it actually separates the different lipoprotein fractions. And so that is why it was designated as the gold standard method. And it's a direct measurement, if you call it, if you can call it that, of the cholesterol or triglyceride in each of these fractions.
And as regards reference intervals, so many of us in the lipid world would say, even forget about the derived, just even total cholesterol, HDL and LDL, you shouldn't even use reference intervals anyway. So this is where we go for risk engines, be it Framingham, Q-Risk, and others. So, and that would be the same for the derived lipid profiles. It is so. In a way, actually, while a lot of people look at these risk engines as individual scores, they're really actually population-based approaches. But you can come up, it's more about clinical action points than anything else. And similarly for irrespective, and I'm happy to have other thoughts on this, if a calculated LDL is above 5 millimoles persistently, or non-HDL above 5.8 millimoles per liter persistently, I would say just treat anyway. Even if they don't have genetic FH and a low risk engine, because you're getting the confidence intervals and the likelihood of something of risk over time are both quite wide and likely. Mm-hmm. What do you think of that, Andrew?
Yeah.
Agreed. So we use decision limits, or desirable level ranges for these lipid parameters. What's the usefulness of lipoprotein electrophoresis? Teaching.
Teaching. Well, maybe I can comment on that. So I think lipoprotein electrophoresis has virtually disappeared, and very few laboratories do it. And I think only a couple of labs in South Africa do it, and then I've come across one other lab that does it in New Zealand, and then possibly I don't think anybody else does it. But I guess for some for type 3, it's probably useful for diagnosing type 3 if you don't have any other types of investigations, and or if you've got other body fluids that you're suspecting might be a leakage of lymph into like a chylothorax or something like that. That's the other occasion where it might be done, but it hasn't completely. I think part of the reason is that we still find it useful, certainly in our setting, and so it is offered. And certainly some of the in Cape Town as well, the lipidologist there, Professor Dave Murray, is also a big fan of lipid electrophoresis, and he's collected a quite a large collection, so he finds it useful. Yeah, and certainly with that. Yeah, go ahead.
Yeah, no, I was just moving on to the next question because they were. Yeah,
I think we've got about a minute left.
Dr. Toomey, do you want to take this question? The friend with the moderate stroke and the mom. So looking at cardiovascular risk.
Okay, so there's two different issues. One is LP-A. Secondly, so is it clinical? So without knowing the levels, is it clinical or genetic familial hypercholesterolemia? So I think they should definitely get checked genetically, but it depends on what the levels are and so forth. But yeah, I would tend to I have a low threshold for even doing genetic FH in such patients, but I would also check LP-A as well, irrespective of what. So the diagnosis of genetic FH is actually academic for both this patient and their mother. It's actually more of interest to their children and siblings and others. In their case, they're both secondary prevention. They need to be treated aggressively to prevent reoccurrence of vascular disease. So there's two separate things there. I would divide it into the cascade screening and their own treatment, and they both. But yeah.
Thank you very much. I think we've reached the end of our scheduled time. So for those of you who still have unanswered questions, they can be replied to by email from our experts. Thank you to our three eminent speakers, Professor Devraj, Professor Toomey, and Professor Dan Wakup, who had to stay up quite late in Australia to deliver this webinar. So a special thank you to you as well.
Yes.
And thank you for all the valuable information you've provided. And I want to thank the IFCC for offering this opportunity for e-learning. And there is a certificate of participation that will be provided at the end of this webinar after you answer a few questions. And then you'll be able to generate your certificate of participation. And furthermore, if you've missed any of this webinar, you can access it on demand, and the link will be sent to you because you registered for the webinar. And there will be other IFCC webinars coming up, and those will be announced if you're on the mailing list, and you'll receive notification of that. So thank you all thank you to the speakers, and thank you to the audience for attending. Thank you and goodbye.
Thank you.